Welcome to the Cenario Podcast, your guide to mental health and well-being. Each episode, we uncover practical tools, discuss expert insights, and explore how supplements can transform your mental health journey. Get ready to learn, grow, and thrive with us.
Welcome to the Deep Dive. We're your shortcut to getting genuinely informed. Today, we're really digging into something serious, often hidden: binge eating disorder, or BED. We've gone through a lot of sources, clinical studies, medical journals, treatment guides. Our goal, a clear, stigma-free look at this condition. And, well, you need to know this right off the bat. Binge eating disorder is actually the most common eating disorder in the United States right now.
It really is. That prevalence, it's kind of staggering. And it shows just how much the public understanding needs to catch up. It's so critical to get this clear from the start. Based on everything we've read, BED is not just overeating, not at all. It's a complex, serious mental health condition. It's officially in the DSM-5, the Diagnostic and Statistical Manual, and that means it needs, clinical help, not just trying a new diet.
Okay, let's unpack that definition then, because it sounds like the details really matter. The behavior, the internal feeling, not just how much food. The sources say a binge episode involves typically eating a large amount of food in, about 2 hours?
Usually within a 2-hour window, yes. But that's only part of it.
Right. The key part, the thing that makes it clinical, is that feeling of losing control.
Exactly. That loss of control is absolutely central. It's the diagnostic linchpin, really. It's this feeling, sometimes like being numb or disconnected, where you just can't stop eating. Even if you're full, even uncomfortably full, or not even hungry to begin with. Psychologically speaking, it often functions as a kind of temporary escape, a way to cope with overwhelming feelings by just focusing on the food.
Ah, that makes sense. So it's an internal experience, not just something you can measure from the outside.
Yeah.
And this is where distinguishing it from other conditions like bulimia nervosa is really crucial for people to understand, isn't it?
Absolutely crucial. The main difference setting BED apart is what happens after the binge, or rather what doesn't happen. People with BED typically don't engage in those regular compensatory behaviors like making themselves vomit or misusing laxatives or exercising excessively to sort of cancel out the calories. They might feel awful and restrict food the next day, sure, but it's not the consistent pattern of purging you see in bulimia.
Okay, but if those more visible compensatory behaviors aren't there, does that make BED harder to spot? Maybe seem less serious to outsiders than bulimia?
It definitely can. That's a major issue. The sources are clear that the intense shame and self-loathing are just as profound in bulimia. But because the binge eating itself is often done in secret, and you don't have those immediate physical red flags like purging, it often goes unrecognized for longer. Diagnosis gets delayed. It can get masked by other things too, like depression or anxiety that might be more obvious.
Right. So let's get specific about the behaviors. If someone's having that loss of control, what other signs are clinicians looking for?
Well, beyond the large amount of food and that loss of control, the sources point to several specific symptoms. Things like eating much, much faster than normal.
Okay.
Or eating until you feel physically uncomfortable, like painfully full. Eating large amounts even when you're not actually feeling hungry. And then there's the emotional piece. Often eating alone or in secret because of embarrassment or shame, and afterwards feeling really disgusted with oneself or depressed or intensely guilty.
Wow. That sounds incredibly distressing.
It is. And for it to be a clinical diagnosis, according to the DSM-5, these binge episodes need to happen, on average, at least once a week for 3 months. It's that frequency, plus the significant emotional distress and the impact it has on your life, your work, your relationships, that separates BED from, say, occasional overeating during stress.
Okay, definition clear.
Yeah.
Now let's talk consequences. This isn't harmless behavior. What's the actual toll, physically and psychologically?
The physical effects are really significant, and they go way beyond just potential weight gain, though that is common. The sources really emphasize the increased risk for serious obesity-related health problems. We're talking things like type 2 diabetes, high blood pressure, heart disease.
So major chronic illnesses.
Yes, major. But also, there are more immediate quality of life issues, things like chronic fatigue, problems sleeping, and persistent digestive issues, acid reflux, stomach pain, maybe even irritable bowel syndrome symptoms. These can make daily life pretty miserable, and sometimes people focus on treating those symptoms without realizing the eating disorder is the root cause.
And the psychological side. You mentioned it feels like a trap, this cycle. Can you walk us through how that works? How does it keep going?
Yeah, it's a really vicious cycle, and it's depressingly good at keeping itself going. It often starts with some kind of intense emotional distress, maybe anxiety, sadness, stress, loneliness, boredom, even unresolved trauma. That feeling triggers the urge to binge, almost like reaching for a coping tool. The food provides a kind of temporary relief, a numbing, or just a distraction.
A brief escape.
Exactly. But then, almost immediately after the binge ends, that initial distress comes roaring back, only now it's amplified. It's layered with intense shame, guilt, self-disgust, often terrible feelings about one's body.
Oh, wow.
And that horrible feeling, that just fuels the need for more emotional coping down the line, setting the stage for the next binge. So you get this loop. Distress leads to binge leads to shame and more distress, which leads back to binging. It's why things like depression and anxiety are so often intertwined with BED.
That sounds incredibly isolating. Okay, before we get to breaking that cycle, we have to address the myths, the misconceptions that stop people getting help. The sources point out two really damaging ones. First, the idea that BED only happens to people who are overweight.
Ugh, yes, this is such a huge barrier. The reality, based on all the clinical data, is that people of any body size can have BED, any weight. Because remember, the diagnosis is about the behavior, the binge eating, the loss of control, and the emotional distress it causes. It's not defined by your BMI or what you look like. So many people who are in normal or even underweight categories might be struggling terribly but think, well, I don't look like the stereotype, so maybe I'm not really sick enough, or maybe this isn't a real problem. It's so damaging.
It completely ignores the internal experience.
Completely. And it ties into that second big myth.
That it's just a lack of willpower.
Yeah.
That you just need to try harder.
Exactly. That one makes me... Well, it fundamentally misunderstands what's going on. We're talking about a complex mental health condition. It has roots in biology, psychology, our environment. It's not a moral failing. Willpower alone just isn't equipped to fight this.
Let's break down those contributing factors then. The sources talk about a mix of influences. What about the biological side? Genetics, brain chemistry.
Yeah, there's definitely evidence pointing toward biological factors. Genetics seem to play a role. There might be some inherited predisposition, but the brain chemistry piece is really interesting. Research suggests differences in brain systems that regulate things like impulse control and how we process rewards. For some individuals with BD, there might be deficits in what we call executive function. That makes it harder to resist immediate urges, like the urge to eat. Their brains might get a much stronger reward signal from food in that moment, overpowering the part of the brain that's supposed to say, okay, stop now, you've had enough.
Which makes the just use willpower argument sound even more simplistic.
Right, it ignores the underlying neurology.
Okay, so biology is one piece. What about the psychological factors? Things like past experiences, emotional coping.
That's another huge piece of the puzzle. Psychological factors can really amplify vulnerability. Things like a history of depression or anxiety, or maybe significant unresolved trauma from the past. Low self-esteem and persistent body dissatisfaction are also major risk factors. For people dealing with these issues, food can, over time, become this learned coping mechanism. It's accessible, it provides that temporary numbing. Even though it's ultimately destructive, it feels like a solution in the moment for overwhelming feelings or stress.
A dysfunctional coping strategy, essentially.
Precisely.
And then there's the world around us, the sociocultural pressures.
Yeah.
How does our environment feed into this?
Oh, the environment. It's like pouring gasoline on the fire.
Yeah.
We are absolutely swimming in diet culture. Constant messages about unrealistic beauty standards, the idea that thinness equals health or virtue or success. It creates intense pressure and body dissatisfaction.
Which can lead to dieting.
Exactly. And restrictive dieting, trying to severely limit food intake, is actually one of the strongest predictors of binge eating episodes. Your body and mind fight back against that deprivation.
So it creates this awful trap. Society tells you to be thin, you try to diet restrictively, your biology rebels and triggers a binge, you feel immense shame, and that shame might lead you back to restricting, or just feeling hopeless.
It's a perfect storm. And we also can't discount negative personal experiences, things like being bullied or teased about weight, especially during childhood or adolescence. Those experiences can leave deep emotional scars that people might later try to soothe with food.
Okay, the complexity is really clear. This demands professional help. If someone hears this and recognizes these patterns in themselves or someone they know, what's the path to getting a proper diagnosis?
It really starts with reaching out to a healthcare professional, a doctor, a therapist. They'll conduct a thorough assessment, usually involving a detailed interview. They'll ask about the binge eating episodes, how often, what they feel like, the loss of control. They'll use those official DSM-5 criteria we talked about. And importantly, they'll need to confirm the absence of those regular compensatory behaviors to make sure it's BED and not bulimia. They might also use specific questionnaires to understand the level of distress and how much it's impacting daily life.
And the good news here, the really important message from the sources, is that BED is very treatable. So what does recovery look like? What works?
Yes, recovery is absolutely possible. Treatment usually needs to be multi-pronged, addressing the behaviors, the underlying emotional stuff, and any other mental health issues present. The sources consistently point to cognitive behavioral therapy, CBT, often a specialized form called CBTE for eating disorders, as being particularly effective. It's considered a gold standard.
How does CBT help specifically?
Well, CBT works by helping people identify and challenge the unhelpful thoughts and beliefs that drive the urge to binge. Like, for instance, that all-or-nothing thinking. I ate one cookie, I've blown my diet, I might as well eat the whole box now. CBT helps you catch those thoughts, examine them, and develop healthier coping strategies instead. It targets the thinking patterns directly.
Makes sense. And medication. You mentioned one earlier, lisdexamfetamine or Vyvanse, sometimes known for ADHD, right? How does that fit in?
Yes, that's right. Lisdexamfetamine was actually the first medication specifically approved by the FDA for treating moderate to severe BED in adults. And the reason it can be helpful, interestingly, ties back to that brain chemistry we discussed. It seems to help regulate neurotransmitters involved in impulse control and attention areas where some people with BED might have difficulties. So it's not primarily working as an appetite suppressant, though it might have some effect there. It's more about helping to strengthen that ability to pause and resist the overwhelming urge to binge. It targets the impulsivity.
Okay, interesting. So it addresses a potential neurological component.
Exactly. And sometimes other medications, like certain antidepressants or even some anticonvulsants, might be used too, especially if there are co-occurring conditions like significant depression or anxiety that need managing alongside the BED.
Which really highlights why the sources emphasize needing a team approach, doesn't it?
Absolutely. The ideal treatment involves integrated care. You really want a team working together. That might include a medical doctor for monitoring physical health, a therapist for the psychological work like CBT, and very importantly, a registered dietitian who specializes in eating disorders.
Why is the dietitian so key?
The dietitian plays a vital role in helping to normalize eating patterns, challenge those rigid food rules that often come from diet culture, heal the relationship with food, and ensure nutritional needs are met. Addressing the physical deprivation side is crucial to reducing binge triggers. It's a holistic approach, mind, body, behavior.
Got it. And one last thing to confirm, this isn't just an adult issue, right? Kids and teens can develop BD too.
They definitely can, yes. It might look a bit different, maybe more secretive eating, hiding food wrappers, rapid weight gain that seems unexplained, or a lot of distress around food or their body. The sources stress that getting help early is really important for younger people to prevent it becoming a more entrenched pattern. Treatment often involves the family, using approaches like family-based treatment to support the child or teen.
So wrapping up, what really strikes me today is just how prevalent BED is, yet how hidden it remains due to misunderstanding and shame. It's clearly a major public health issue.
It truly is, and raising awareness is step one. We need people to understand it's a real treatable medical condition, not a character flaw. Dispelling those myths about willpower and weight is crucial. Understanding the complex interplay of biology, psychology, and our environment, that's how we build compassion and pathways to effective help.
So here's something for you, our listener, to think about. We've heard BED is complex genetics, trauma, societal pressures like diet culture all play a part. Recovery is definitely achievable, but it takes time, often months or even years of professional integrated care. Knowing all that, especially the biological roots and the powerful role of societal pressures, how might that change the way you personally think and talk about food, weight, and health within your own community? How could you help foster an environment that's less about judgment and more about understanding compassionate support for recovery? Because the final message here is one of hope. Recovery isn't just possible, it's expected with the right care and support. If anything we discussed resonated, please know that healing is deserved and help is out there.
Thanks for tuning in to the Cenario podcast. Don't forget to visit Cenario.com for more expert tips, articles, and supplements designed to support your mental health. If you enjoyed this episode, remember to subscribe and share it with a friend. Until next time, take care of yourself.